Hi, you're watching DNA Today, a multi-award winning genetics podcast where we explore everything to do with genetics, from CRISPR to rare diseases to new research. We have won the Science and Medicine Podcast Award for many years now. We have hundreds of episodes, and we really hope you enjoy these conversations where we dive into so many genetic concepts. I'm Kira Deneen, a certified genetic counselor, and your host. As Rare Disease Month comes to a close and we head towards Rare Disease Day, we're turning our focus beyond the U.S. to explore rare diseases in Brazil. So in this episode, we're going to dive into how rare diseases are diagnosed within Brazil's healthcare system, the unique challenges Brazilian families face compared to patients in the United States, and how whole genome sequencing is changing the diagnostic journey for rare disease patients in Brazil. To guide us through this conversation, we're joined by Dr. João Bosco, who helped lead Brazil's National Rare Disease Genomics Initiative, the Brazilian Rare Genomes Project, and now continues to work through his lab at NeoGenomica. We're also joined by Victor Camilo from MGI, who brings perspective on how sequencing technology supports these large-scale rare disease efforts. So Dr. Bosco and Victor, thank you so much for coming on the show and helping me celebrate Rare Disease Month.
Kira, it's my pleasure. This is a great month for rare disease in the whole world. And we know genomics can help those folks a lot. So it's a pleasure to talk about this.
Thanks for the invitation.
Yeah, appreciate you both coming on. And Dr. Bosco, I mean, you've had quite the career, and specifically your impact on genomics in Brazil is really impressive. I'm just a little starstruck that we're able to have you on the show today.
Thank you.
To start us off, from a technology and industry perspective, why is Rare Disease Day such an important moment in Rare Disease Month to talk about genomics and whole genome sequencing from this global perspective? Because you've worked in many countries. You did some time at NIH here in the United States. So you do have a nice perspective of just kind of how Brazil compares to other countries.
Sure. As I said, it's my pleasure to be here, Kira. And yes, I think we cannot understate how genomics has been important for the rare disorders, right? We talk about rare, but we know that it's a very large number of diseases that fit that category, right? If it's one below roughly one person affected for less than 2,000 people in the general population, we call it rare disease, a rare disorder, right? But we have at least 9,600, so close to 10,000 different rare disorders. So as a group, we estimate there are more than 500 million people affected by rare disorder in the world. And in Brazil alone, maybe more than 13 million people. So it's not a rare problem, right? It's a very common problem that affects a large number of people. And genomics has served a very important role for those people over the years. In the first phase, we had a discovery phase, because when we got to have these next generation sequencing or highly powerful tools to sequence not one genome, one panel, but the whole genome, a whole exome, we started discovering many of these diseases, right? Discovering the genetic base of those disorders. And now we are, for the last few years, in a phase of ample adoption of this for the diagnosis, right? That's the first step in this long journey from diagnosis to have access to therapy, to counseling. But I think this being very central, the adoption of these technologies are very central to evaluating, discovering, and then now evaluating those patients.
And it's changed so much. And you've single-handedly had a major impact on the accessibility of genetic testing for people in Brazil. Because from my understanding, before your lab and your efforts with the Brazilian Rare Genomes Project, if a patient needed to get genetic testing, that had to be sent outside of Brazil. And so that's going to add to the turnaround time. But you were able to start genetic testing so that patients could get genetic testing within their own country in Brazil. Tell me about how that looked as you were starting that.
Sure. It wasn't just myself, of course, right? It's always a group effort. But yes, back in 2019, when we started the Rare Genomes Project, there was no nationally led effort to do genomics in Brazil. So we set up this project in cooperation with the Ministry of Health of Brazil. At the same time, another colleague of mine, Lígia Arruda, started a population genomics project. And with these two, let's say, seeds, the Ministry of Health decided to have a national genomics project, the Brazilian Genomics Project. And then our two projects were the first ones, one for rare disorders, one for population genomics. And I think our role is, in the Rare Genomes Project was to first to show how WGS or whole genome sequencing could be a very powerful tool to make a diagnosis, right? So we recruited over 10,000 people in all 5 regions of our country over the last few years. We trained folks in the healthcare system, all public system. So in Brazil, we have the private sector for health, but we have a very large public health system. And this project was funded by the Albert Einstein Hospital, that's nonprofit, but given to Dawn completely in the public health system, right? So we recruited over 10,000 people. We trained folks in over 25 different centers in Brazil, north, northeast, south, southeast, and middle of the country. So they got used to requesting tests. We helped them to interpret back the results and then apply this knowledge to the patient, to the patient's benefit. So we saw a large, very interesting change from people not understanding at all or understanding very little or using very little in the day-to-day to being very comfortable using these tools along the time and actually depending on them. What we tried to do later was to give all these protocols to the Ministry of Health. And now the Ministry of Health is starting again, not funded by a nonprofit like we had, but funded by the own government, a large scale diagnostic. So they're incorporating the technology now in the public health system, pretty close to what happened in England, where you had a project first leading and then you had an adoption. So I think there was we learned how to deal with it, larger scale infrastructure for bioinformatics, training of people to read the results and then make reports, and then how to use it at in the clinical side. So I think I'll be very happy that we have actually left some good legacy for the government now to implement in real life, not outside of a project.
That's a lot to be accomplishing in about 6 years because you said that started in 2019 and we've just started 2026. So that's just impressive of in that short amount of time of how much you've been able to accomplish with your team. And a big part of that we're talking about with being able to have genetic testing in Brazil is the technology side, right? Because you have to have the right tech to actually make this happen. Victor, to pull you into the conversation, from your vantage point working across Latin America, how do technology partnerships help address disparities in access to this advanced sequencing? Because before Dr. Bosco got involved, like there were so many disparities of just people not being able to access this testing. And even if they could access it, it would take so long to get results because it had to be sent to a different country.
Exactly. Thank you, Kira. So from my perspective, this type of partnership across Latin America, it's key to try to reduce the inequality and the access that we have. Because here in the region, in all Latin America, we have a lot of good scientific talent. Bosco knows very well. But all those talents, they go abroad. They go for a PhD and they stay abroad. We have so the talent, but the infrastructure, the funding, and the access for the technology here in the region, it's not evenly distributed. So across the countries, even inside Brazil, is not even distributed at all. So partnership here is key to help to bridge the gap. So if you're combining the global technology or the most cutting edge technology and you have the brains here, so those partnerships brings to the region a lot of good efforts and good results, like you can see.
Yeah. And I think it's so important. We've been talking about really whole genome sequencing and how that's particularly powerful for rare diseases compared to panels and exomes. We're really moving more towards just going right to whole genome sequencing in a lot of cases. Can you explain why we're really more focused on whole genome nowadays?
Yeah, sure. Great question, because in the past we used to do a lot of WES or whole exomes. And it remains a lot of incredibly important in advancing for heart disease diagnostics. But GS or whole genome sequencing is a step further. ES or exomes are only 1 or 2% of the genome, and they are directly linked to the coding proteins, to the coding part of the genome that coding proteins. So whole genome take everything. So you have access to a lot more information, and you can take like regulatory regions, variants in structures, copy number variation changes, no coding region areas. So it increases a lot of the information that the researcher will have in hands to try to find something that it's unique. It's not there, it's not common. So it's key. Dr. Bosco is here. He can talk a lot about this. So the WGS is key for this type of discovery.
Yes, and if you allow me to chime in, Kira, we actually quantified this in the whole genomes project, right? Our paper is coming out now, but we analyzed the first 9,000 whole genomes, and we saw, as compared to whole exome sequencing, we increased the absolute percentage of diagnoses, right, of diagnostic yield by 6%. So 6% absolute number, right, from going from 20 to 26% of positive yield. But it varied according to the phenotype. For example, for neurological, neuromuscular disorders, it increased 12% because we started capturing stuff that the whole exome actually missed. For example, very small deletions of duplications, very hard to find by whole exome sequencing, right? 1 or 2 exon deletions and duplications are almost invisible to whole exome sequencing. We started getting intronic variants, of course, because they are not represented in the whole exome sequencing capture region. We got repeat expansions using new tools to detect expansions. We know short read is still not the ideal platform to get expansions diagnosed, but still we increased 1.5% more of diagnosis because we now have software to do this. And we got mitochondrial structural variants or mitochondrial variants that are co-sequenced. When you sequence a whole genome, you usually get a lot of mitochondria. So every one of these categories were adding up. And I always say, one resolved case is one resolved family, right? It's one family that at least has an answer. In the worst case scenario, at least they got a name now, and they at least close the first chapter of this sometimes very long time to get to this diagnosis. So it kept adding up, and as I said, it's about 6%. I saw what Dr. Heidi Ram did at the Broad, and she got about 8%. So we're pretty close. But so there is actually a quantifiable increase in the diagnostic yield by using these platforms. As I said, I think that the holdout before was a cost, right? But now with this large instrument like we have the MGI T7, where the cost per gigabase it went down, it made possible to bring whole genome sequencing to the forefront. So currently, I don't think it makes any sense by looking at the price point now to use other tools. As very, very specific exceptions, but as a rule, I think we're going to move to using this tool more and more in the routine.
Yeah, it just makes sense. And when you think about, we're talking numbers, percentages, but I really like how you brought it up, Dr. Bosco, of like, that's a family that now has an answer. And now they can look and find other families in the world and connect with them that also has this diagnosis and that sense of community. And there's so much that comes out of that, even if there's not specific medical treatments or interventions we can do for that rare disease yet. But then they can be paying attention to what new research comes out, and it really gives them a better scope of what they have with their kiddo, because most people that are getting a rare disease diagnosis are kids these days. And I think that's a great point of like cost, unfortunately, is a big aspect of this. So over the decades, like since the Human Genome Project wrapped and back in 2003, like we have the cost just dramatically dropping so that it's feasible that we can actually do this. But there's other aspects to this too, of like the technological advances that make it worth it to do large scale whole genome projects like this. Victor, what are your thoughts on this in terms of like sequencing accuracy, throughput, these costs? Because a lot of this has to do with the technology that MGI is developing so that scientists like Dr. Bosco have these really good sequencers and other technology to be able to make this happen for a cost point that is feasible.
So the quality is improving over the time. We have all the time new chemistry, new library prep kits, and everything towards to have more quality. This is development of the industry that is naturally happen. But other than to have good quality and also good technology, you have to have a end-to-end solution. It's mainly here in the region that we are not like US at all. So we have a lot of drawbacks. So when a provider has end-to-end solutions, since extraction to the analysis, as Dr. Bosco said, it's a key point. You rely on one provider to give you the whole line to develop your research, like extraction, automation to do the library prep, which is increase your quality because you don't have any bias doing it by hand. So everything is automatically. So then you have sequencing. So yeah, the cost drop off a lot, and it's still dropping. And yeah, of course, the main goal of the provider is to have the research focus where they have to be focused, and not in the other part of the process. I mean, my goal is to make Dr. Bosco to focus on the data analysis and do the findings, and not the other parts behind. We let the machines do it for him.
Yeah, try to make it as seamless as possible, because figuring out and doing the data analysis, like, it takes a lot of effort and time, especially when we're looking at rare diseases, because you don't always know exactly what you are looking for. And it is more of a general search, and you don't necessarily have like, oh, well, this family member has this, and so we're looking at that certain condition. That's usually not the case when we're looking at rare diseases, because so many of them are random, de novo, or if they are inherited, other people in the family haven't been impacted maybe by that rare disease yet. So it's usually a very like new case that we're looking at. And Dr. Bosco, I'm curious in terms of the collaboration, because obviously, like we've talked about, there's a lot of people had to be involved in this as the project was started. How did the collaboration work between clinicians that were like with the patients, that were their healthcare providers, to more like on your side with like research and being in the lab? And then, you mentioned like government and industry. Like, how did they all come together for the success of the program in such a short amount of time?
Right. I mean, as you know, there's a lot of people have to work together to make it work. Of course, it's not a super large scale project, but at least 10,000 samples is the first was the largest project we had at the time, and we did need all of them. It was very interesting to see how it evolved. Right, we had to get the clinicians involved. Of course, they have to approve in the local IRBs. Brazil is not like in the US. We have one approval, and then all centers are covered. Here, we have to approve place by place. Every hospital had to approve a therapy. So clinicians have to get involved. They have to feel that the project is important for their patients, because they have to take time from care, right, to enroll the patient. We have some paperwork, and they sometimes they're afraid of the results. They didn't know how to deal with the genomic result, didn't know what to expect sometimes. I didn't know how to deal with the unknown result, like a variant of unknown significance. It was very interesting to see how they went from this at the beginning, being very comfortable, knowing the genomics, very powerful, but you just leverage like any other test. Sometimes you do not get the results. Sometimes they are, not definitive. You have to reanalyze data. You have to reanalyze a VUS in the future. So it was very nice. They got involved. Of course, they had to get involved. Of course, they are the main stars of the project, right? They recruit everyone, and they learned a lot during the process. And I felt at the end, they were just like, could not stop using anymore those tools, because they saw how they benefit the patients. Of course, our job as the researchers were to make the best of our data. We designed sub-analysis, for example, for ICU, kids in the ICU, and we just published in that. We had some phases where we tested other tools, for example, transcriptomics as a complement to the genomics analysis. We use a little bit of long read sequencing to see them and to capture some of these variants that are not captured by short read sequencing. And of course, we had to build all the infrastructure to get these electronic phenotypes, get all the genomic data, put in a central database in a way you could mine this. And the role of the industry and government was supporting us. Government was, of course, they had to oversee the project, approve it, and they were very proactive. And they actually, now it was good because we got into this era now of genomics in Brazil. And it's very much, they're very involved still with the project. They want to complete 100,000 samples over the next couple of years. Industry was less of a partner. I don't know why. We had this, it was not like in England that we started a lot of industry. The industry here was represented by the hospitals. Albert Einstein and all the hospitals are providing the funding. Yes, every one of them had to have this specific role. And yes, we had to get together every month and realign and recheck until we got this. But now we have maybe over 10 projects in the Brazilian Genomes Project, not only Rare Genomes Project anymore. So we have many more ongoing with more, maybe now 25,000 samples are ongoing in different centers. So it really picked up some speed now.
Yeah, I'd say so. That's a lot of samples. That is just
Yeah,
so
this
impressive.
is
And
going
we
up,
haven't yet talked about the company that you started,
right?
NeoGenomica. So
Yes,
tell me, how did that come about? Because I'm imagining from your experience and your pivotal role in the Brazilian Rare Genomes Project, it kind of led to this. Am I getting the
yes,
timeline right?
absolutely. Yes, we had a lab before, then we sold it to a hospital. But now, when we saw the power of the whole genome sequencing as the main tool, so I decided to open a new lab just centered around whole genome sequencing. I said, I'm not going to do whole exome sequencing. I'm not going to do panels. The cost is low enough now. We know the power. We have the knowledge to build the infrastructure for bioinformatics and the trained personnel to get, to do the data analysis. That's very important, as you know. I think it's the main bottleneck is moving from generating data and for processing data now to analyzing data. So we decided to open this lab. And now, instead of focusing on equipment, right, we're focusing on tools, software tools, for example, to help, as you said, to pick that one or two genes out of the 20,000 that may be defining that person diagnostics, right? So rankers, how to use AI to help the analyst to get data from a website, for example, to see if a variant has a functional paper showing it's damaging that sometimes by hand you cannot find. So we focus now on the main thing, that's applying WGS to every phenotype for pharmacogenomics, for prevention, for diagnostics, and building tools to help to reanalyze data, reanalyze variants of unknown significance, help in the ranking, and help the data collection that's very important for a final decision of what's causing this disease, what's increasing that risk for that specific patient. So that's the idea. Bring WGS to life full in Brazil.
And it's great that you did just make the decision that it's like, no, we're only offering one type of task, the sequencing of just the whole genome. I mean, within that, as you mentioned, you could do short read, long read, like there's different things that you can kind of play around with, but just saying, okay, we're going to be cutting edge here. We're not going to be doing panels or exome.
Yes.
And Victor, I'm thinking like in terms of your role with this, how does MGI support labs like Dr. Bosco's NeoGenomica that are aiming to bring these cutting edge genomic sequencing technologies into routine clinical care where it's very novel, like within Brazil? So this is just one example of so many, especially in Latin America, Victor, where your clients are, of saying, okay, like, how are we going to set this up so that it really works in this kind of workflow?
Kira, it's easier than you thought because it's just one test. It's only WGS. You have of course, we do have a backbone behind us supporting on engineer side, scientific side, but everything comes easier to us because it's only one test. We only have to care about WGS, and we don't have to take care of many variants for many tests that's out there. It's just one variant, I mean, for variant on the support side. Yeah, that's a bit easier, but for now, Bosco is the pioneer of this era on WGS, and as well was in the sequencing in the past, and here is a pioneer on WGS here in Brazil, and I think that Latin America is the only lab that's driven only for WGS. So from the equipment perspective, it's easy because the MGI technology is towards WGS. So we do have sequencers like T7, T7 Plus that is focused on delivery WGS as fast as possible. The turnaround time is shorter, and the cost per sample and cost per gigabase it's dramatically low right now. And we do have all the machinery, all the automation equipments behind, like XP960 to do the library prep. And we have all the servers to where the researcher or the laboratory can host all the applications that they must host to analyze the data and provide everything. So it's a straightforward support when we talk to WGS because this is what MGIs know very well how to do.
Yeah. Yeah. I think it's such a great partnership, I think, between MGI and Dr. Bosco's lab with NeoGenomica, and obviously all the work you did before you started the lab. It's just really impressive what you've been able to offer to people with rare diseases in Brazil. Is there anything you want to leave listeners with of just thinking about it being Rare Disease Month and maybe where you hope that we're headed in terms of like the short-term future of rare disease care within Brazil? Anything on your mind within that, Dr. Bosco?
Sure. I think the main thing is exactly what's the day for, to raise awareness. I think people take too long to think of a rare disorder and to send to a center or to send for a genomic evaluation. No, genomic evaluation is only done, good or bad, when the patient it's there. But someone thinks of a diagnosis and sends out the sample, right? And then we can help using the best tools we can have to speed it up, make it less error prone, make it faster and cheaper. Of course, that's very important for the patient. But first thing is to remember, if you're dealing with an unusual patient, if you are dealing with a kid that's very sick at the ICU and it's not very obvious, there's a 60% chance, for example, of being a monogenic disorder. So I think this awareness that not only for the patient themselves, of course, they can look for care, but for the journalists, for the clinicians, think of this central tertiary center where can they get attention. Now we get the tools to make the diagnostic faster. And remember, a diagnosis is only the first step, like Kira. After this, we have a lot of different steps to improve the life of this patient and of this family. But I think awareness. Think that maybe a rare disorder. Send to someone to be evaluated, and then at the end, we hope you're going to be correctly evaluated. We reach a diagnosis, and then we start or continue a better treatment plan. So that'll be this. And of course, as a policymakers, uh, we need more events. We need to train more the workforce. I think awareness, it's a very big problem. Now we have lower costs. We have a better infrastructure. I think training and awareness is going to become even more important to help those people.
Yeah, I agree with that. Anything to add on to that, Victor?
Yeah, of course, thinking in the heart disease day, Dr. Bosco said everything. So technology is there. So now we need to educate people. We need to train people, not only in the sense of the to use the machines, but as well the families. We need to educate everyone on the technology, to receive well the technology, to embrace the advancement, to be possible to these guys do what they know how to do, the best
Yeah,
that can do.
definitely. Well, happy Rare Disease Month to everybody. I think this was a very
Happy.
positive episode of just what can happen in just a few years, the future of rare disease diagnostics. And we didn't talk too much about it, but care would be the next step, is just very bright. And I think there's so much that's happening so fast that it's just very promising and an exciting time to be working in genetics. And for families that have someone with a rare disease, the outlook is good in terms of just how many advancements that we're making. So Dr. Bosco and Victor, thank you so much for coming on and celebrating Rare Disease Month with me.
Thank you. It's my pleasure, Kira.
Thank you.
Pleasure.
Thanks for watching DNA Today. To access all of our episodes, head over to dnatoday.com. We also have a lot of bonus content on there that you can enjoy. If you have any questions, comments, suggestions, guest pitches, you name it, send them in to info@dnatoday.com. We'd also really appreciate if you could take a moment to rate and review the podcast on Apple, Spotify, wherever you listen to the show. It really helps more nerds like yourself find the show. Also, if you like giveaways and other ways to connect with us, I recommend following us on social. We're at DNA Today Podcast. We also have a Patreon if you want to be the most level involved in the show. That's also at DNA Today Podcast. Thank you so much for listening and watching. Join us next time to learn and discover new advances in the world of genetics.